Good day, everyone, and we are down to our topics for the finals. So let's start with broad spectrum compatibility testing. Compatibility testing is a term often considered synonymous with cross-matching. However, in the transfusion service, a broader view of this term is taken. Compatibility testing includes the recipient identification, sample collection and handling, and required pre-transfusion testing. This approach ensures that the greatest compatibility or no adverse reactions from transfused blood technically possible between the donor unit and the proposed recipient. The process begins with the transfusion request and ends with the transfusion of blood product to the patient. Because the antibody screen, ABO and D phenotyping and donor testing are discussed somewhere. So this topic only concentrates on the issues related to cross-matching, a component of compatibility testing, and provides an overview of important steps in the process of compatibility testing. Our objectives for this week are the following. First is to define compatibility testing and cross-match. Second is to discuss the principle and importance of broad-spectrum compatibility testing. Third is to enumerate and prepare the equipment and materials needed in broad-spectrum compatibility testing. And lastly, interpret and report the results of broad-spectrum compatibility testing accurately. Now let's have a short history of blood transfusion. So the history of compatibility testing and transfusion practices is an interesting progression of events that begins with the discovery of the circulation of blood in the year 1628 by William Harvey, and an event that made the first human venous transfusion possible. So the first in vivo transfusion was attempted with animal blood and later human blood. Using a quill or a metal apparatus introduced into a recipient's vein, early recipients often died because no understanding existed of ABO blood group system antibodies, as it was elucidated by Landsteiner in the year 1900s, or of other blood group systems alloantibodies. Direct transfusions were performed again in the first decade of the 20th century with some success, despite the lack of compatibility testing. So a cross-match procedure was first attempted in the year 1907 in New York by Weil and Ottenberg. Sera of recipient and donor were separately subjected to lengthy room temperature incubation with red cells from the opposite sources to detect hemolysins. Major and minor cross matches were part of routine testing. Antibody screening did not become routine until the late 1950s to mid 1960s. Progress from the era of no testing to a century of rapid discoveries led to a proliferation of testing protocols that peaked in the 1960s. And then a movement existed for the discovery and characterization of every possible blood group antigen and the detection of every corresponding antibody. Now let's differentiate what is compatibility testing and cross-match. Compatibility testing, this encompasses all the steps in the identification and testing of a potential transfusion recipient and donor blood before transfusion in an attempt to provide a blood product that survives in vivo and provides its therapeutic effect in the recipient. While cross-match are performed prior to administration of the blood and blood products, in which the purpose of cross-match is to detect the presence of antibodies in the recipient against the red blood cells of the donor. And then, these antibodies attach to the red blood cells of the donor after transfusion. So an incompatible transfusion can result in a severe hemolytic anemia and even death. The figure on the right shows the process of compatibility testing. So the process begins at the recipient and ends with a safe transfusion into the recipient. Now let's proceed to the principles of cross-match. The rationale for the performance of the cross-match is twofold. So the cross-match was added to compatibility testing to prevent life-threatening or uncomfortable transfusion reactions and maximize in vivo survival of transfused red cells. The cross-match procedure attempts to fulfill these goals in the following ways. So the cross-match serves as a double check of ABO errors caused by the patient misidentification or donor unit mislabeling. And the second principle is if the recipient possesses a clinically significant antibody or a history of one, the cross-match provides a second means of antibody detection and checks the result of the antibody screen. The cross-match is designated to detect donor units and likely to survive normally once transfused. The cross-match is designed to detect donor units unlikely to survive normally once transfused, so the test must be rapid and simple enough to be practical. Actual measurement of the survival rates of transfused red cells in vivo may be the best cross-match. So this technique can be performed directly through the use of radioisotope labeling, but is impractical for regular use. Instead, post-transfusion hematocrit or hemoglobin values are often determined to provide a working measure of a successful transfusion. 1 unit of transfused RBCs should increase the hematocrit by 3% and the hemoglobin by 1 gram per deciliter. Now let's proceed to the standards and regulations governing the cross-match. So the AABB standards provides the most exclusive summary of cross-match standards. So the cross-match procedure must be performed using the recipient's serum or plasma and donor red cells taken from a segment originally attached to the blood product bag. So a segment is a sealed piece of integral tubing from the donor unit bag that contains a small alico of donor blood used in the preparation of red cell suspensions for cross-matching. So the cross-match defined by the AABB standards is a technique that shall use methods that demonstrate ABO incompatibility and clinically significant antibodies to red cell antigens and shall include an antiglobulin test. Again, an exception is provided. So if no clinically significant antibodies were detected in the current sample or in the patient's past records, an immediate spin cross-match is permitted to fulfill the requirement of detecting ABO incompatibility. So these pictures on your right shows the uh, actual segment of a blood product. Now let's proceed to serologic cross-match versus your computer cross-match. Serologic cross-match provides a procedure test that the recipient serum or plasma with the red cells from the donor unit in either an immediate spin cross-match or an antiglobulin cross-match. So the immediate spin cross-match may be used for recipients with no evidence of clinically significant antibody or antibodies in the current sample and in the historical record. So in this procedure, the recipient serum or plasma and donor red cell suspensions are mixed and observed for agglutination. This procedure meets the AABB standards for detecting ABO incompatibility and can only be done using the tube method. And then the immediate spin cross-match may be used for recipients with no evidence of clinically significant antibody or antibodies in the current sample and in the historical record. So in this procedure, recipient serum or plasma and donor red cell suspensions are mixed and observed for agglutination. And then, while the second one is the computer cross-match, it uses a computer to make the final check of ABO compatibility in the selection of appropriate units for transfusion. And now we have two parts of our cross-matching procedure. So it is divided into major cross-match and minor cross-match. So major cross-match, this is the most important one because in this procedure, we are looking for antibodies in the recipient against transfused red blood cell antigens from the donor. Therefore, we need serum from the recipient and red blood cells from the donor. While minor cross-match, this detects antibodies in the donor serum to the recipient's red blood cells. Therefore, for this, we need serum from the donor and red blood cells from the recipient. And we also have the so-called auto-control, in which we also perform an auto-control with our cross-matches, that is, the recipient serum with your recipient red blood cells. So this picture shows the difference between major and minor cross-match. And please take note that a cross-match is performed prior to administration of blood or blood products, that is packed red blood cells. And then the purpose of the cross-match is to detect the presence of antibodies in the recipient against the red blood cells of the donor. So those antibodies attach the red blood cells of the donor after transfusion. And then, an incompatible transfusion can result in a severe hemolytic anemia and even death. Okay, so this figure shows the difference between major and minor cross-match. We also have the limitations of our cross-match testing. So the antibody screen and the cross-match have inherent limitations as separate tests and should be used together. A recipient could have a negative antibody screen result in an incompatible cross-match. A negative antibody screen does not guarantee that the recipient's serum does not have clinically significant red cell antibodies. The negative antibody screen means that the recipient's serum contains no antibodies that react with the screening cells by the method used. So in this example, a recipient might possess an antibody directed against a low incidence antigen not contained in the commercial screening cells, and a cross-match might detect this situation. An antibody detected with screening cells might not react with a weak expression of the antigen or donor cells in a cross-match, leading to the situation of a positive antibody screen with compatible cross-match. A compatible cross-match also does not guarantee the optimal survival of red cells. Aspects of the patient's clinical course, such as bleeding, red cell sequestration, may limit the benefit of the transfusion. A delayed transfusion reaction could occur if a pre-existing undetectable recipient antibody is boosted in the strength by the infusion of the corresponding antigen in the donor unit and rapidly destroys the donor red cells. Even if the red cell destruction does not occur, a recipient may become alloimmunized to the donor antigens, rendering subsequent compatibility workups more time-consuming and complicated. Non-life-threatening transfusion reactions may also occur, making the transfusion uncomfortable for the recipient, such as hives, low-grade fever, chills, and itching. Now let's proceed to the materials and equipment used for performing this procedure. So you need your Wassermann test tubes, gloves, pasture pipette, Nasco film, normal saline solution in a wash bottle, marking pen, gum label, and a centrifuge. Next, the reagents and sample used for this method. So we have our 2 to 5% red cell suspensions of donors and patients' red cells. And then we also have your patients and donor sera, and then antihuman globulin sera, 22% bovine serum albumin. We also have the patient samples for compatibility testing, maybe serum or it can be also a plasma. And then plasma samples are preferred. So plain tubes with a red top or no anticoagulant, and purple or pink top. So the anticoagulant for our purple top is ethylene diamine tetraacetic acid or EDTA. So tubes are the most commonly used. So many laboratories have adopted the pink stoppered blood collection tubes for blood bank samples. The collection tubes are spray coated with dipotassium EDTA and provide anticoagulated blood with plasma and red cells for testing. Historically, any form of anticoagulated anticoagulated blood sample was discouraged for compatibility testing. Anticoagulants inhibit complement protein activation. So that's the reason why. So our cross-matching or our compatibility testing has three phases. So the first one is the protein or albumin or room temperature phase. So the procedure for this one, so first is to label 4 Wassermann test tubes as M, MA, and NA respectively. Next is you have to follow the table below, wherein M stands for major cross-match, major cross-match, so patient serum plus the donor's red cells. And then MA stands for major cross-match with albumin. And then N stands for minor cross-match, in which patient's red cells plus the donor serum. And then NA is our patient's red cells plus donor serum with albumin. So for the major cross-match, so for the patient serum, you need 2 drops, and then 2 to 5% suspension of donor's red cells, 1 drop. For our MA, 2 drops of patient serum and 1 drop of 2 to 5% suspension of donor's red cells. As for our minor cross-match, 2 drops of donor serum plus 1 drop of 2 to 5% suspension of patient's red cells. And then for our NA, we have 2 drops of donor serum and 2 to 5% of patient cells, 1 drop. And as well as our BSA, 22%, 2 drops for both MA and NA. After that one, so you have to mix the contents and cover the tube with Nesco film and centrifuge for 15 seconds at 3,400 RPM. And then next is to gently dislodge the cell button and observe for agglutination or hemolysis, as you can see on the picture on the right. So if no agglutination or hemolysis is observed, only the major cross-match with albumin and minor cross-match with albumin tubes will proceed to the thermo phase, which is the next phase. And please take note that low ionic strength saline or LISS may be used instead of 22% bovine serum albumin as an alternative if the tubes proceeding to the next step will be incubated for 10 minutes only. Now let's proceed to our thermo or incubation phase or 37 degrees Celsius phase. First is to incubate the major cross-match with albumin and minor cross-match albumin tubes showing no agglutination for 30 minutes at 37 degrees Celsius in a water bath. Again, if you are going to use your LISS, you can incubate the tubes for only 10 minutes. And then centrifuge for 15 seconds at 3,400 RPM. And lastly is to gently dislodge the cell button and examine for agglutination or hemolysis. If no agglutination or hemolysis is observed in the tubes MA and NA, we will proceed again to the next phase, which is the antihuman globulin phase or the AHG phase. So first, what are we gonna do with our AHG phase? So you have to wash the cells of tubes MA and NA with NSS at least 3 times. And then you have to decant the NSS completely after the last washing. And then you have to add 2 drops of antihuman globulin sera. And then you have to centrifuge for 15 seconds at 3,400 RPM. And you can gently dislodge the cell button and examine for agglutination or hemolysis. So if there are tubes that has no agglutination, then you can add 1 drop of your Coombs check cells to tubes showing no agglutination. Next, how are we going to interpret the results? So if it is compatible, then there is no agglutination or hemolysis in all the tubes tested. If it is incompatible, then there is agglutination or hemolysis present in any of the tubes tested. So we have various cases here on how are we going to interpret the results from your various phases of the compatibility testing. So the first case, so in the protein phase, it is negative for both the major and minor cross-match. So therefore, blood is compatible both in major and minor cross-match, and then blood is safe for transfusion. As for our second case, there is an agglutination or positive reaction in the major cross-match for the protein phase, but in the minor phase, in the minor cross-match rather, so all the phases have negative results. So blood is incompatible in major cross-match since there is an agglutination reaction in the protein phase, but it is compatible in minor cross-match since all of the phases have no agglutination reaction or hemolysis. So therefore, we conclude that blood is not safe for transfusion. The next case, so there is an agglutination both in the major and minor crossmatch in our protein phase. So blood is incompatible for both in major and minor cross matches, and blood is not safe for transfusion. So the last case, we have no agglutination reaction for all the phases in our major cross match and an agglutination reaction in our minor cross match. So blood is incompatible in the major cross match but incompatible in minor cross match. And we can conclude that blood can be transfused but with major caution. Okay, please take note of that. And that ends our discussion with regards to blood spectrum compatibility testing. I hope that you have learned something. Thank you so much for listening and God bless you all.